Uh, my topic of this lecture is a newly developed clear S8 SGTB treating severe skeletal class 2 anomalies. I'm Dr. Jing Feng, Chief Ortho Specialist from Shanghai Premier Dental Care. And this is my brief bio. The Premier Dental Care is one of the prime private dental establishments in Shanghai. And before that, I worked for the Nice People's Hospital affiliated to Shanghai Jiao Tong University for above 13 years. And at that time, I worked with Professor Shen together, and we contribute a lot to the research and development of SGTB and now the clear version of SGTB. So the lecture overview is 3 parts. The first of all, we're talking about the new diagnostic classification system for malocclusions with facial prognathizm, because that is a route for our clinical practice, and that classification will tell you the indication of the S8 SGTB. And the second part, we're talking about the detail about the therapeutic restoration of the malpositioned mandible with Smartee S8 SGTB. And at last, we'll show some radiographic evidence of TMJ remodeling with S8 SGTB therapy. Okay, the first part, new diagnostic classification. This new diagnostic classification for the facial prognathizm have many components as following: facial profile examination first, and intraoral manifestations, and malocclusions etiologies behind the appearance. And most importantly, we pay much attention to the mandibular position. It will contribute to the malocclusions forming dramatically, and the TMJ conditions. Also, we will give the treatment modalities according to each classification of this facial prognathizm. Okay, here are 5 categories, and today my lecture will concentrate on the highlight 3 ones. They all have some common things, but most importantly is mandible position. Mandibular position is retruded, is transferred, is translated backward, and they all have class 2 molar relationship. Okay, if you have these 3 categories, they are the strongly indication for the SGTB. The etiology factors causing mandibular retrusive positioning. Why all these 3 categories have the backward placed mandible? Because the constricted upper dental arch and the mandibular backward translation to match upper dental arch width to achieve masticatory efficiency. So with the backwards placed mandible, the consequences will be class 2 molar relationship, deep over jet, and deep over bite, and deep covert speed. We call that 3 depths. So how should we treat 3-depth cases? Distalization, and sometimes distalization are not workable or are not reliable, because sometimes the inclination of the molar has already been tilted distally. So distalization cannot be suitable for this kind of malocclusions. And extraction, if you extract some case of the 3-depth malocclusion, it will be very dangerous or risky for you, because we have a lot of second-hand cases. They extracted some case for the 3-depth malocclusion, and they cannot close the space, or they still have the deep overbite or jet in the patient's mouth. So extraction is not a good option for us. And surgery. Surgery may be the last resort for us, but most of the patient cannot accept surgery, and that will be harmful and expensive. If we can provide the patient some other options with harmless solution, that will be better. So we are doing the harmless solution, SGTB, to move the lower jaw forward to do the cases to solve the problem, focusing on the main problem, focusing on the main source. And say it again, for the 3 highlighted categories, we have the common things 3 depths and class 2 molar relationship. For this kind of cases, we can use the S8 SGTB to move the mandible forward. The therapeutic restoration of the malpositioned mandible to relocate the deviated lower jaw into its normal position, enabling a subsequent correction of the malocclusion. We at the early stage, we use a bonded SGTB. We have a long history of using it, maybe 25 years. So we can see the pictures of the typical design. The sagittal guided twin block was fixed or bonded SGTB. The upper piece cannot be removable, and the lower piece is movable. But the patient have to wear the lower piece to have a good position of the mandible. They guided here is a oblique plane to guide the lower jaw forward to the normal position, and it is very reliable. Here is a case using the bonded SGB. It's a 12-year-old boy. His main complaint is protrusive, the protrusive upper lips and retrusive lower jaw. And see the intraoral photos. It has the 3 depths malocclusion and class 2 molar relationship. You can see some spaces during the arch, upper arch. Is in very, very deep overjet and overbite, deep curve of speed. With this case, it's the typical indication for the SGTB, bonded SGTB. So we use it to move the lower jaw forward to the normal position. Yeah, you can see with the SGTB in his mouth, the deep overbite and the overjet was relieved immediately, but it's not stable. And with a block exists between the upper and lower dentition, the lower jaw cannot move back, and the patient have to wear it 24/7 days to stimulate the TMJ and to train the muscle to remember this position. And after 10 months, the lower jaw cannot move back, and you can see the deep overbite was opened, and overjet is opened, and but still some open bite at the buccal segment. This is not the fault of the SGTB, but it's the fault of the deep curve of speed, because we move the lower jaw forward and expose the deep curve of speed at the buccal segment. But don't worry, we can close this open bite by extruding the lower molar and the upper molar together. It will be very easily to be fixed. Okay, this is the end result of this 3-depth malocclusion without any teeth taken out, with no distalization, of course with no surgery. We restored this malocclusion in a very smart way, and the improved dramatically. You pay attention to the nasolabial angle. The nasolabial angle for the patient is not bad in the first place, and for this kind of patient, if you extract any teeth of the upper arch and retract the frontal teeth very much, it will ruin the nasolabial angle, and also will restrict the lower jaw, the position, and the lower third of the patient will be retruded, both upper maxillary and mandibulary. So it's not what the patient wants. And why we developed the clear version of bonded SGB, S8, that S8 SGB, because a bonded one is so bulky and not very easy to clean. So, and we cannot control the lower incisors and the individual tooth position. The treatment duration will be about 2.5 to 3 years. So that's the disadvantages of the bonded HGTB. So we are now using the clear version of HGTB. It physically looked similar to the bonded one, but it has a digitalization and algorithm equipped within it. It can provide precise, accurate, and efficient movement of the tooth, and it also will provide you a predictability. The evidence of Smartee S8 is repositioning the mandible and correcting the malocclusion simultaneously. We can see some cases to understand how it works. The first case is a young adult, 25 years old. The first visit is 2020 in May. The chief complaint is protrusion and crawling. That is one of my earliest cases. The initial extraoral photos showed the upper midline was 1 minute to the right, the facial asymmetry, and the long face. Nasolabial angle was more than 90 degrees, mandibular retrusion. Pay attention to this nasolabial angle. More than 90 degrees, that means the upper lips are not protrusive quite much. So the main problem contributed to this malocclusion is the position of the lower jaw. The protruded mandible is a source of this kind of malocclusion. And the intraoral photos show 3 depths, molar class 2, crawling both upper and lower dentition, and the scissor spite at the terminal dentition. Okay, some secondary caries and fillings in her mouth. And the OPG showed no upper wisdom teeth and 2 impacted lower wisdom teeth, and the condylar symmetry were acceptable. But the molar, you can notice the molar inclination is tilted mesially. The Ceph showed the same things. The nasolabial angle is not bad. The inclination of the upper arch is upper incisor is a little bit increased, and the lower jaw position is retruded. It can be seen from the SMB is the data is reduced and ANB is increased. So why the ANB increased? Because the point of B moved backward. That means the jaw position translated backward. So according to the course, we should move the lower jaw forwards, either not move the upper incisor backward. So the treatment plan first stage advancement of the mandible with S8 SGB and expand the upper arch, extract 3/8, 4/8 to correct the scissor spine of the second molars. And second stage to leveling the curvus B and further interdigitation. Okay, the protocol. Stage 1, mandibular advancement together with individual teeth correction. That's the advantages of this clear version SGDB can provide. Oh, that's a picture of the patient with a wax record in her mouth after moving the mandible forward. Yeah, you can see a little bit unnatural on her face, but don't worry, it will disappear within 3 months at most. And tell your patient to get used to it, to wear it 24/7. It will getting better and better. Yeah, this intraoral photographs after reposition of mandible with wax records in her mouth. Yeah, when you move the mandible forward, the open bite at the buccal segment can be exposed. So that's another proof. The open bite is not the fault of the SGTB, right? It's a deep curve of speed. Okay. This is an animation. Yeah, you can see we correct the scissor spine at a very early stage and expand the upper arch, provide some spaces to relieve the cordings, together with some IPR to provide more space. And we try to distalize the lower molars to upright them. Yeah, from this view, the same. Expanding, distalization of the lower molar, and scissor spine corrected. And the lower, the mandible was positioned forward at the same time. So it will provide you high efficiency. Okay, that's the intraoral photographs with aligners at step 1. You can see the buccal segment, the buccal block with the anatomical indentation. It's fixed for the upper and lower tooth very tightly, very solidly. And this is the step 10, the 10th set of the aligners, where the lower jaw move forward significantly, and the facial profile was improved. And you can see the expression and the muscle lines are getting naturally. And the intraoral photos show the scissors bite was corrected. So it's very, very quick, because when you open the bite, the scissors bite can be corrected much easier. But something not favorable happened, because as I said, it's very early cases of my experience using S8 STDB. The aligners wasn't fitted well on 3.5 and 3.8. The intrusion of 3.7 is inadequate, and the premolars are tilted mesially. The root of lower incisors are more inclined. So that's not what I want. But don't worry, we have the opportunity to fix it. So I ordered MCC. You can see the panoramic radiograph before the MCC, the molar, especially lower side, lower left side, tilted mesially very much. And yes, and the intrusion of the lower molars are not quite enough. The SEF analysis for MCC, the same thing. The lower incisors inclination is getting worse, and the inclination of the molar tilted mesially. That's not very good. So we have to fix it. How? We order MCC, and we take the back the record again, and still move the lower jaw forward as the same. Yes, and this is intraoral photograph. But this time I use a MIA to help me upright the lower molars and control the incisors inclination, and together with the mandible move forward. Yes, you can see the animation. The upper arch was expanded further, and the lower molar move backward with the assistance of MIA on both sides. Yes, from this view, we'll see it clearly. Also, some IPR to provide space to relieve the crowdings and make good control of the inclination of lower incisors. Okay, that's a nice set of liners. The profile have been improved, and the curve of the profile, is very beautiful. The lower jaw, the chin point move forward, significantly. And the intraoral photos show, it's actually where like 10 months to 10 months with a block. So the mandibular position was stable, and with this stable position, we can either extrude the molar or premolars, or intrude the incisors to flatten the tip curve speed. For this case, the patient don't want to increase her facial height, so we decide to intrude lower incisors instead of extrude the molar and premolar. And it can be balanced to your aesthetic consideration. Okay, the extra photographs for the second stage, and after the mandibular forward movement, it is the 15th set of aligners. And the inclination of the molars and the premolars are getting better, more upright. And the upper and lower quadrants are relieved mostly. The frontal areas open bite, the overjet open bite at the normal range, still a little open bite at the buccal segment is not too difficult for us. Yeah, from OPG, you can see clearly the MIA in the lower arch to assist us to upright the molars and retract the frontal teeth and give the good control of the inclination of the lower incisors. Yeah. And the staff analysis for the second stage. Yeah. This time, the lower incisors inclination, yes, was controlled acceptably. And yeah, A and B, yeah, sorry, its reading is not mandibular advancement. Okay, that's it. Oh, the second, yeah. For the second stage, the inclination of the incisors are at some control, and the superimposition, showed we have to do more work furthermore to control the incisors in the future aligners. So we have to do more dissolidation of the molars and maybe more IPRs to upright the lower incisors and make counterclockwise mandibular rotation by intrusion of anterior teeth and mandibular posterior teeth. So the treatment protocol for S8 SDB stage 2 is doing the interdigitation. Yes, for this stage, not too much work left. Just do a better interdigitation, more control of the lower incisors, and flatten the curve of speed. Okay, this is okay. This nearly the sixth number of the new set of aligners. Yeah, you can see the the height of the lower third is not increased, right? And the curve of nasolabial and mentolabial angle and the curve is very smoothly. Intraoral photographs, still some open bites and some space. Midline is almost on, and still a little crawling left. Okay. Okay. Improvement of facial profile, and we're near the end of the treatment. Yes. At this time, we spent 18 months to achieve this result. I think it's fast. And at that time, the patient moved to another city to work. So we have to do some refinement to coordinate the patient's schedules to do the detailings. Yeah, with the help of the MIA, we have a good palpation of the roots and very good uprighting of the lower molars. And the proclination of the incisors are getting better. Yeah, some more details. Not too much thing to finish it. That's the results of the treatment. It take about 2 years, including maybe 3 months to 4 months prolonged because of the job changes. I think the result is satisfactory. Thinking about the initial intraoral photos, crooked teeth, the scissors bite, the deep over jet, deep over bite, and class 2 molar relationship, all fixed. And without any teeth taken out, and no, of course, no surgery. And good palpation of the roots, and no root resorption. A little bit, yes, we leave the MIA a little bit longer to maintain the results. And the lower incisors inclination was controlled into an acceptable range from 2020 to 2022. Yeah, almost like 2 months, like 2 years. Fix all the problems. Yes, I can see the procedure. The patient was very happy with these results. And and after the mandible advancement and at the end of the treatment, the big difference can be tell. The superimposition, yes. The lower jaw move forward and downwards, and the lower incisor proclined a little bit. but still in acceptable range. And the profile, the facial profile is improved dramatically. Okay, let's move to the second case. It's an adolescent case. This is a young boy, 12 years old. The initial extraoral photos show a little bit deviation of the lower jaw to the right side. And the midline, the upper midline is on, and the lower midline shifts to the right side as well, and chin towards to the right. From the lateral view, the lower jaw position is backwardsly placed. Okay, the initial intraoral photos, not too much crowding, but you should notice this, the upper left lateral palatally displaced, and that may be the main cause of the lower jaw move leftward, and so the midline of the lower dentition shifts to the right side. And the lower arch at the left side, the teeth compensationally tilted in and not very symmetrized. Mild crowding in both upper and lower arch, lingually tipping molars and premolars. And from the OPG, the shape and length of the mandible, the TMJ, the condyle, is not so asymmetry. So the deviation of the lower midline mainly because shift of the bodily shift of the mandible to the right side due to the palatally placed lateral. And from the ceph, still the lower jaw position is positioned backwards. With deep curve speed, deep curve speed, deep overbite, deep overjet. And in this case, the lower incisors inclination was also proclaimed already at the initial period. So this treatment time still also use S8 SGP to forward relocation the mandible and expand the upper arch, especially the left side, and partially correct the midline. I will explain it later. And distally moving the lower left molars to give you space to retract the lower incisors. Second stage, extend molar to adjust the occlusion and symmetrize the lower dentition to meet the midline on. Treatment protocol for S8. Okay, stage 1, mandibular advancement together with individual teeth correction. That's the picture after mandibular relocation. We move the lower jaw forward and partially correct the lower chin point. No, not a chin point, not partially correct the lower midline. We correct the chin point this time completely. And why the upper and lower incisors, the midline, are still not on? Because the deviation of the midline is partly caused by the inclination or the tilted in of the frontal area, frontal teeth, lower frontal teeth. So we just move the lower jaw straight forward, and without the constrict of the upper lateral, the midline was corrected atomically, but still something left. We have to correct it using the inclination. So you can see we expand the upper arch mainly on the left side to relieve the guidance of the lateral. And because the left side is molar relationship, class 1 molar relationship, so if we move the lower jaw forward, this side will become class 3 molar relationship. So we have to distalize the molars to get the class 1 molar relationship. And that will provide some space to upright the lower incisors and correct the lower midline further. The extraoral photographs just at the initial stage, the number 3 set, the chin point move backward, move to the normal stage, normal position, and but this time it's not stable because just three sets, and the midline is it's not stable as well. But at the 10th aligners, the chin point is on, and the lower incisor, you can see lower incisor getting better because the lower jaw's position is more stable now. Yeah. And the buccal open bite was appeared. But don't worry for it, because with the space we can extrude the lower molar or premolars very easily. Mandibular advancement. Yeah, that's the end of the end of the stage 1. Yes. The occlusion was stable. That means that the lower jaw cannot move back. And with this stable position, we can close the buccal open bite very easily and safely. Still a little bit midline shifting, but don't worry, we can fix it very easily because the lower incisor tipping to the right side, and that's why the midline shifting is still something left. So we just have to upright the lower left molars to create some space and upright the lower incisors, and the midline will be on. And this time, the inclination of the lower incisors basically maintain the same as the initial situation. And at stage 2, we do the interdigitation. For this low angle case, we determine to elongate the premolars and molars much more than intrude the lower incisors. And you can see the lower incisors inclination was corrected beautifully. Yes, yeah, at that stage we use some button to to help the elongation, but now we just use reduce the buccal, the height of the buccal block gradually, and the teeth will be elongated very easily. At the end of the treatment, the chin point is on, and the lower midline was on also, and the lower jaw, the mandible, was positioned forward, and very beautifully interdigitation presented. Oh, yes. This case, the roots paralleled beautifully, and we suggest the patient to take the wisdom teeth out maybe 2 years and 3 years later. We take a good control of the inclination of the lower incisors and move the lower jaw forward pronouncedly, and we maintain the straight profile. And for this low angle case, we do the job to try to clockwise the plane of the mandible. And this case just to take less than 2 years, right? Maybe 20 months to finish all the things. And this interesting young boy lose a lot of weight to be more handsome, and of course with our contribution to his handsome. And the intraoral photos, the midline, take a look at the midline, partially corrected, and lost its own beautifully. In the molar relationship, both sides class 1. The shape of the arch wire, the upper end arch and lower arch are coordinated beautifully. And the profile improved, and the lower jaw position moved forward and stable, yeah, distinctively at very short time. And the superimposition, okay, time, oh, I have to be quick. SHSDB orthopedic mechanism is the retract and expand the maxilla, relieve and advance the mandible, regenerate condyle remodeling, and relocate the mandible before repositioning the teeth. And I will quickly show the radiographic evidence of TMJ remodeling with S8 STDB. Don't worry about the consequences will be stable, because we do a lot of research both on the animal research and the human beings radiographic evidence. For the rats, the adult rats, compare the natural growth and condyle remodeling growth. Even for the adult rat, under the stretching force, the endochondral ossification was triggered. You can see that the cells on each layer is active, and the condylar remodeling happened. And OPG inspection of the human beings also show the proof. The new cortical bone contour appears on the condylar surface. Yeah. Before and after the SDB, the double line on the top of the condylar is very pronounced. And CBCT also showed the new bone formation is very distinct. After wearing 7 months S8 STB, yeah, the new bone formation can be checked. And MRI inspection, MRI is a golden standard of TMJ problems. It showed the condylar new bone formation contributing to restoration of TMJ components. Yeah. The highlight area is a new bone formation. Okay, lecture summarization. Advantages of Smartee S8 STDB is repositioning the mandible and correcting the malocclusions simultaneously, correcting severe class 2 jaw discrepancy, minimizing the need for surgery and extraction, a promising treatment efficacy in adult patients, shortening treatment duration due to high efficiency. So that's a smart appliance from Smartee. Okay, thank you for your attention, and welcome to have a visit to our clinic in Shanghai.
So shall we just go through the questions one by one?
Okay.
In the Q&A box, there is a question that, can we use class 3 mini screw and class 3 elastic in this stage? This was a question left quite early, at the early stage of your presentation.
I guess your question is about the distalization of the lower molars, right? If you want to distalize the lower molars, we do need the mini screws help, but we don't suggest using the class 3 elastic, because it will provide the opposite force to the forward position of your mandible. When you move your mandible forward, you want the force is consistent. If you wear the class 3 elastic, it will give the opposite direction of the force to move your lower jaw backward. So that's not our suggestion. You can use a screw to help upright your tilted in molars or premolars and distalization of your lower molars, but don't use class 3 elastic.
Okay, thank you. Let's move on to the next question from Thomas Felke. How could you consider by planning the amount of forwarding of the mandible, the eventual auto rotation of the mandible after expanding the upper arch?
Okay, that's a very good question. I didn't mention it during my lecture, but when during your clinic job, you have to look at your mandible position, and you can simulate it at your clinical work. You let the patient move the jaw forward and see the change of the profile. Normally, the upper and lower incisor have to be edge to edge, and a big open bite appeared on your buccal segment. But for some special case, essentially special case, mainly focusing on the retroclined upper incisors, we call it class 2 division 2. Class 2 division 2. The retroclined incisors means the amount of the upper arch move forward even more than the straight frontal teeth cases. So maybe you have to move your lower jaw forward a little bit more and make a reverse overjet, like 1 millimeter, and open the buccal segment at least 4 to 5 millimeter height. That's a tips of the WAT record.
And the next question was raised in Chinese, and it says, after the mandibular advancement, what is the stability at the later stage, and is there any change on the joint? I guess it probably means TMJ. Is there any change?
Yes. That's a very common questions be asked. Many doctors, many orthodontists worried about the stability after the advancement of the mandible, especially for the adult patient. But to our clinical experience and our opinion, the TMJ have the ability to be to have the remodeling ability for the whole life. So if you give the TMJ the sustained force, stretching force, stimulate the endochondral ossification, the new bone will be formed. That will be the key point of the lower jaw stability. And in our clinical cases, so many cases showed after the 5 years, 10 years follow-up, the lower jaw forward positioned, the 10 years later, the occlusion and the facial profile was all stable and as usual. So don't worry about TMJ.
All right, that's great. Another question is about, what does MCC mean? I think this abbreviation shows, but next to intraoral photos.
Yeah. MCC mean, to do it all over again because some problems happened. Just do it once again. Yes.
Okay, just do it once again.
Yes.
All right. Next one is also a very good question raised by Chris Guzman. He said for SGTB cases, is S17 active mandibular retainer required to use, or just the basic retainer will do?
Wow. So Chris maybe have used the Smartee appliances already. So S17 is a very good appliance to maintain the results after forward positioned mandible. And for me, if I just suggest the patient to wear S17 for they have some TMJ problems, they are not these three categories. They are the first two categories. There are 5 categories, and the second categories need the S17 retainers, but the other 4 categories, I don't suggest they wear it, because the main cause of the malocclusion is different.
Okay, so it really depends on the situation.
Yes.
The next question is stage 1, does the patient wear the trays when eating?
Yeah, sure. Yeah, they have to wear it 24/7.
Right.
Yes, or especially when eating, because when you chewing something, your muscles and your TMJ are being active mostly. So you have to grasp this period to relocate the lower jaw forward and stimulate the TMJ to have new bone formation, and let the muscle to remember the new position. That will be helpful to your results after remove the blocks. That the memory will lead the muscles will lead your lower jaw forward to the new position.
Mm-hmm. Okay. Next one is about the age. May I ask, is there any age limitations for Smartee S8 used? It's from Mohammed Doresh.
Age limitation. It's getting be elder and elder. Yeah. Yes. For me, the biggest one, the eldest one, maybe 45 years of old. But just like I said, the formation, the new bone formation ability will be lifelong. So just for the elder people, the ability will get maybe not strong. Not as strong as younger people, but it's still some ability left. So for the elder people, you maybe wear more time, or the amount of your lower jaw should be bigger. That will be suggested.
Yeah, for Smartee patient, one of our patients for Smartee S8 is like 68 years old, and it works really well.
Okay. Okay.
The next question from Annis Alomeri asks, what if patient didn't eat with it? Does it still work well?
Okay. I guess no. If the patient didn't eat with it, the muscles practicing and the stimulation for the TMJ not good enough. So the lower jaw position cannot be stable.
Okay. Yeah. So it's almost mandatory to eat with the aligner, particularly at stage 1. Yeah.
right?
Okay. So the next question from Pratik Sharma is about the how to progress the case once SHTB or SHHB have been used. How we progress, I guess, from stage 1 to stage 2. At what point we send stage records after stage 1? What records do you need? And how we hold correction while we're waiting for stage 2 aligners to arrive. I guess what she or he means is what the doctors will do between the transaction periods from stage 1 to stage 2. Like while they are waiting for stage 2 aligners to arrive.
First of all, after you finish the stage 1, your mandible have to be stable already. So even without the blocks in your mouth, the mandible cannot move backward. That means it's safe when you're waiting for the stage 2 aligners to arrive. And either stage S8 TB or SHHB, you have to choose the right indication for each type of S8. And you have to wear it long enough, the duration for the stage 1, at least 10 months, and have to be wear it during mealtime. And after your examination at your clinic, you can push your lower jaw backwards, and they cannot be moved backwards, and it maintain the same position. It's stable. It's right point to move to the stage 2 aligners.
And the next one is about the relapse for adult patients. What is the chance for the adult patients to get relapse?
Adult patients relapse. I would like to say, if you choose the right indication and do the right protocol, you will get the stable relapse. And if you worry about the relapse, you can tell the patient to wear S17 to maintain it for lifelong. If you don't choose the right indication, it may be the biggest chance for the relapse of the adult patient. And the duration is essential key for the stable relapse.
And the next question is quite similar. It's also asked about the relapse, the chance for relapse in adult patients. Would you advise the need to wear retainers while with locking device to prevent higher chance of relapse? I guess the answer is yes.
Yeah.
Right?
Yes. Right.
Yeah. Next one, do patients can chew food during wearing SPTB?
Of course. But they need time to get used to it. At first, you can choose some soft food. And after you master the way of how to chew the food in the right way, you can chew the normal food.
The next question is also quite similar about food, about chewing food. Do patients wearing S8 SGTB chewing food like they do when they wear normal twin block?
Normal twin block, you mean the removable twin block?
Yeah, is there any difference in terms of chewing food? I
guess the removable twin block is not fixed to the dentition as much as S8 STDB, because the clear aligners can hook the teeth, every teeth, very tightly. And when you chewing the food, it will be stable and more comfortable.
The next question from Chris Guzman. What are the chances of relapse for SGTB cases, and how long should the patient wear the retainer after the treatment?
Okay. Similar question. Yeah, similar question.
Yeah.
If you use SGTB cases for the three highlight categories we're talking about today, the chance of the relapse is very, very small. And if you worry about it, you can tell your patient to wear the S17 retainer to maintain the results at least for 2 years.
Mm-hmm. Okay, so it's at least for 2 years. Okay.
Yeah.
Wow, really a lot of questions on the list. It says, I'm impressed with how the SGTB works. Now I'm wondering if you had ever encountered from any of your patients complaint of orophacial pain, given that there's a smooth remodeling of the condyle region. Or are there any reported cases of relapse?
Okay.
Have you encountered any of your patients?
Okay. Yes, sometimes the patient will complain the discomfortable or even clicks on the TMJ or orophacial pain on the TMJ area during the first 3 months. But as I said, don't worry about it. The TMJ need time to reconstruct, remodeling. So normally they won't occurred or won't appeared after the 3 months wearing.
Mm-hmm.
Yes, and you have to tell the patient, don't be worried about it, don't panic, and they will be get more faith for your treatment, and that will be helpful also.
Okay. Yeah, it takes a little bit of time for the patient to get used to it.
Yes.
Yeah. Next question is about S17 retainer. Is S17 good for ulcer treatment?
I think so. I think it can be used for ulcer treatment because the ulcer treatment mainly because backward positioned mandible. So it's a similar source, similar reason for the treatment. So SS17 is good for it, but pay attention to the occlusion situation because S17 can just move the lower dentition forward with a flattened curve of speed. So if you have a deep curve of speed, you cannot use S17.
Yeah, so the short answer is yes.
Yeah.
And this next one, this is changed every 14 days also. I guess it means the change of aligners to the next day.
Aligners every 14, maybe 10 days, depending on the patient's compliances.
Mm-hmm. Okay. Oh, is this the last question? Will it not cause open bite if you wear the retainers for 2 years?
No. Just like I said, you have to have the flattened curve of speed. So no curve of speed when you move your lower jaw forward, no open bite appeared.
Mm-hmm. Okay, great. Oh, one more.
One more?
More. Nice and clear. Thank you for answering my question. I think that's almost all the questions have been answered.
Okay.
Yeah.
Thank you all. And for your
Thanks all. Yeah, thank all the great questions from our audience.
Yes.
Yeah. So I guess if you don't have more questions, that almost the end of the session today. So so on behalf of Smartee, I would like to thank Dr. Feng for her excellent speech and her time for answering all the great questions. And I would like also to thank all the audience for joining us today. So I really hope you will find today's session helpful, insightful, and helpful to your clinic practice. So before we finished today, I'd like to share with you the timetable for our next month's webinar.